Hello, everyone. So I'm going to take you through today uh, through an iLearn on how to perform 15-lead ECGs. This session will be available within the recording session, and it won't be available in the presentations folder. And that's because it's in the iLearn format. So the objectives then of this session are to, at the end of the module, you'll be able to perform a 15-lead electrocardiogram, troubleshoot and prevent commonly made errors, perform an ECG on patients with an open sternum, conduct an atrial wire study when P waves are not visible. Now, whether or not you actually do those activities are dependent upon the scope of your practice, because as you know in the course, we have many different interprofessional experts. And also within the sort of rules and regulations in your organization, even if it is within your scope of practice. So today it will be an informative session on, when you would do a 15 lead, how you would do a 15 lead, and sort of preventing some of those commonly made errors. Some of the information also will be specific to sick kids, and you may have something different or even similar within your organization. So we have Epic at Sick Kids, and that entails using a barcode scanner to have the patient's identification, MRN information show up in the ECG machine. Otherwise, if you don't have Epic and you don't use barcode scanning, then it would mean inputting the information directly into the 15-lead machine, which we can also do. The most important thing is that you have two patient identifiers. So you have the patient name, date of birth, or MRN number, two patient identifiers. And what happens if we don't scan the information properly, or we fail to put the information in directly into the Epic or into the 15-lead machine, then the information, or the 12-lead in our system, goes to the Muse database, which is within the Heart Center. And that's where the ECG technologists and also the cardiologists or intensivists review the 15 leads. So although they may be reviewed at the bedside, they receive a final review to make sure that the information is correct going into the patient's chart. So we need to make sure that the information is correct, and we have something on our Epic system and our name bands that there's a QR code, a square code, and I'm going to show you a picture of that, and there's a barcode. So we want people to scan the barcode so all the information gets uploaded into the Epic system. If, however, they choose the square QR code, what happens is letters AC and a few numbers after it get uploaded, and then we actually don't have the patient's information. So it's hard when the ECG transmits wirelessly to the Muse database for the ECG technologist to know even whose chart this is supposed to be reconciled to. So we always have to make sure that the patient's data is input into the system properly. In our particular system, we would turn the ECG cart on, and this will take us to the resting ECG, or the 12 lead, and then the orders will load only to this mode. We would press F1, and we're going to show you a few videos to get into the patient data screen. We would pick up the scanner from the back portion of the ECG cart and hold the scanner about 5 centimeters away from the barcode and not the QR code. And we'd use our thumb to cover the square QR code so we don't accidentally get it. And then press the button on the scanner to allow the green light to scan on the linear barcode. And when the information is scanned, the patient's field will be populated, and also its order number. And it's important also to enter the staff's name who is requiring or the fellow's name who's requiring the 15 lead, as well as you as the user. So if we have any questions, we can always go back to you and reconcile whatever the question is. And also we have a system at Sick Kids where we must enter the location code. And what that means is that the right people are reading it. So to give you an example, in the cardiac ICU, if we're doing a heart center cardiac ICU patient, we would enter 39. And in the PICU, we'd enter 5,000. And then the right people, our cardiac intensive care experts, will read the cardiac ones, and there will be other physicians who read the PICU ones. And that pertains to different areas around the hospital as well. So that may be a difference from your system. Here's an example of our patient's name band, and you can see that there's the barcode and the QR code. We really want people must, in order for the information to be uploaded into the system, scan with this scanner the barcode and cover up the QR code. Otherwise, what happens, AC and several numbers after it, and we have no idea who's this 15-lead ECG belongs to, which means we have to go chart to chart and examine the paper copies that have been placed in there. It's just giving a little bit more information about the scanner. So we would go back to the main menu, and really we want to do a 15-lead ECG on our patients. So we'd press 1 for the patient data, select yes, use the same patient information for the test. So we also want to know what the indication for the test is. So not only do we want to know who's ordering it, who's taking it, but also the patient's diagnosis and why the test is being repeated or being completed. So that might be because the patient is having a fresh post-op 15-lead ECG. It might be because the patient, we can't see any P waves and we're trying to understand what the patient's rhythm is. It might be because the patient is having dysrhythmias. So we want to identify, or maybe they're having some ST segment elevation, and we want to have a closer look around where we're seeing the ST segment elevation. So the test indication. So as we take you through this iLearn, we're going to look at specific aspects of 15 leads and also show you some videos as well. There's some quick check questions, so we'll answer the quick check questions as well. And so so when you are doing a 15 lead, we want it to be a good quality ECG. And so you can see here that we have good quality signal in each of the leads. And there's no baseline sway and there's no artifact. So really we want people to apply the stickers, and we'll show you how, and then to wait till we have a good quality signal. So if a patient is moving around a lot, for instance, that may cause some artifact or some baseline sway. Maybe there's some equipment that's causing some artifact, and we'll go through that. And so what we want is to wait, and when you have a good signal, like the example it's showing here, then to press ECG. And with our system, this may be different from yours, that once you have a good ECG, we only really want you to press the ECG once, because that's the thing, the ECG that will get transmitted through the database to our storage system, Muse database, where our cardiologists will read it, or physicians will read it. And so if you press ECG 10 times, and you haven't waited for a good quality signal and then press it, what it means is it will automatically transmit it 10 times, 10 different ECGs up to the Muse database, and those poor electrophysiologists or cardiologists are going to have to read all 10. So ideally, we want you to wait for a good one. Obviously, if you push it and the patient moves, you're gonna repeat it. If you just want a copy of a good ECG, the ECG when you press that button, it will get sent up. But if you press copy, you can make as many copies as you want. So there's an example of a good quality ECG. Here's an example where we actually have some interference. We have lots of artifact here. We have some baseline sway. and no clear QRS complexes. So we're going to look at some of the ways to try and get a good quality ECG before we begin. All right, so printing rhythm strips. So remember, we can do ECGs and we can do rhythms. And usually we want an ECG and we want a rhythm strip. But when we're doing the rhythm strip, we don't really want you to press all leads. And again, that might differ in your organization, but in ours, when we print off all leads, what you have is 12 leads down on a piece of paper, and sometimes the leads are kind of running into each other. So it makes it hard for it to read, especially if the patient has hypertrophy. So we want you to select either V1, lead 2, V5, or lead 1, 2, or 3. So this is the limb leads, and this V1 and V5 are the chest leads with one limb lead in the middle. So on the machine, we're going to press leads, and we're going to specifically select when we want to do rhythms. Rhythms are not stored to the Muse database, they just print at the bedside. So we'll pick either this or this versus all leads. So here we see a picture of selecting lead 1, lead 2, lead 3, and we just see 3 clear leads come across the page, or V1, lead 2, and V5. And then we have 3 very clear pictures of that. So that's how you select it. We just toggle down to pick the one that we want, and that may depend upon your cardiologist. And then finally, this is what we ideally here at Sick Kids don't want, which is where all of them just print out one after the other. And you can see if there are leads where it's taller, that they actually seem to run into each other. So we prefer that we don't press all leads. In terms of the electrodes and where we're placing them, we can cut them lengthwise to the appropriate size. So if you think of a very tiny baby and this big electrode or sticker, then we're going to have trouble placing all of those across the patient's sternum. So we want to make sure that we've made sure that we've cut them in appropriate size. So for the neonates, what we can do is either half it or quarter it. So we often quarter it. So it depends upon the size of the baby. If we have a very small chest, then we're probably better off quartering it so that we have these placed in the exact spot that we should have them placed. I can't stress enough to you the importance of ensuring correct placement. Many years ago, one of the ECG technologists used to tell me that, you know, sometimes we would put stickers on, down the sternum and then along the ribs, and sometimes they would be sort of straight down like the wings of a bird instead of going around. So we're going to show you the exact placement of how to place them. And again, the cardiologist doesn't actually know where you've placed them. He's relying upon you to place them in the correct spot. And sometimes we have dressing. And many, many years ago, when there was a dressing, well, sometimes people used to move the stickers to the right of the dressing or to the left of the dressing. The problem with that is the cardiologist doesn't know that it's not over the area of the heart that they're supposed to be examining because they didn't watch you do it. And so they may actually be, they may actually have misinformation about the heart and are making some determinations about areas of the heart where the sticker is actually not overlying. So number one critical principle is that if you can't place a sticker where they should be, then just leave it off. It's better to leave it off than place it in the incorrect spot. So again, we have half size and full size for infants, toddlers, and then children. So the right arm and the left arm leads are applied midpoint between the elbow and the shoulder. So really we're putting it halfway between here and here. In the legs, they're applying mid-calf, so not over bony area, but over the tissue. In an emergency, what we can do is just apply all of the 4 limb leads. So, the right arm one, the left arm one, the right leg, so on the calf of the right leg and the left leg. And then if you drape the manifold and all of the leads that come off of it, if you take the 2 on the outside and the 2 on the outside this way, then those are the ones that will be placed on the limb leads. Then the cardiologist, if they're trying to decide what rhythm this patient is, at least they will have the limb leads coming across the screen, because it takes a bit more time to put V1 through V7 and V3R and V4R on the chest. And so, they can decide whether they need to stay or go, depending on what they actually see from the limb leads at least. So there's the chest electrodes. And sometimes, remember, we have sternal dressings covering this area. So if we can't fit the leads in the proper, or the electrodes in the proper place, then we're going to leave off the ones that are being covered by the dressing, unless we can take the dressing off. So when we're thinking about placement, one of the areas that we're going to look at is, first of all, I'm just going to tilt the camera a little bit. So we have our suprasternal notch here, and then we have our clavicle coming across here. And if we go along the side of the sternum, we can see that there's just underneath the clavicle is a little indent between the ribs. So that's the first intercostal space. Then the next indent is the second, the third, and the fourth. So if we're looking at this diagram, here's up here would be our suprasternal notch, and then our clavicle over here, and our clavicle going up here. Here's the first intercostal space, the second intercostal space, the third and the fourth intercostal space. And so, actually, I guess in this picture, the way it's shown is sort of first, second, third, and fourth. Kind of the picture here. But anyway, so first, second, third, and fourth. So the first V1 goes in the fourth intercostal space, right of the sternal border. And then V2 goes on the other side of the sternum and in the same fourth intercostal space. We miss out putting V3 and we put V4 first, V4 next. And there's the clavicle. And so it's mid-clavicular. So if we drew a line straight down from the clavicle, the middle of the clavicle, in the fifth intercostal space, that would be our V4 placement. And then we're going to put V3 in, just slide it in there. And then we're going to forget about V5 for a moment, and we're going to put V6 here, which is along the same plane in the mid-axillary line. So this one's showing the mid-axillary line. And then we'll put the one that goes in the anterior axillary line, fifth intercostal space, which is the V5. And finally, in the posterior axillary line, round the back, is where we put the V7 posterior lead. And on the other side, then we're going to do V3R and V4R. Again, on the we're going to forget about V3 for the moment, and we're going to put V4R. So on the right side, because it's a right-sided chest lead, because in pediatrics we're doing 15 lead ECGs. And so we're going to find the mid-clavicular area, and in the fifth intercostal space, mid-clavicular line. Then we're going to put V3R in between. Okay. So when patients have, so there are modifications for special patient conditions. So one of these is a patient with a temporary pacemaker. So if ECG is required to identify the underlying intrinsic rhythm on a pace patient, well, as nurses, for instance, or ECG technologists, we're not going to turn the pacemaker off unless we have a physician with us. So they ask the MD then can safely turn the pacemaker off. We can get an underlying 15 lead ECG. If we're unable to stop pacing, then we don't actually do the ECG because it's just a pace rhythm. And so we're going to wait for 24 hours to see if a physician can then turn off the pacemaker. So if it is to be turned off because they want to check it, then the MD is going to be the one who does that. They're present, they can turn off the pacemaker, do the 15 lead. So the MD shouldn't use the pause button on the pacemaker to check the underlying rhythm. So basically what they're going to do is to turn down the rate on the pacemaker till it's somewhat of a lower rate, and then the patient's underlying rhythm can identify itself. Then we'll do the 15 lead. For patients with dextrocardia, this slide actually needs a bit of modification because just probably about a year ago, we made some changes to how we do patients with dextrocardia. So essentially in our unit, when we just place the leads on patients with dextrocardia just to the bedside monitor, we don't do right-sided placement. We just put our ECG stickers in our normal placement for our 3-lead ECG monitoring position. And if we're going to do a 15 lead, we do first just a normal placement of our 15 leads. In the past, we used to just take, when we're doing the second ECG, we would do a dextrocardia one, and we would move V5R, V6R, and V7R. So we would move V5, V6, and V7 across to the other side, and then we would do a dextrocardia or right-sided ECG. And on the printed copy, we would write, right-sided ECG, and we would put an R beside V5R, V6R, and V7R. Now what we do is actually move all of so we actually reverse all of the electrodes. So V1, which would have been on the right sternal border, fourth intercostal space, will now move across to the other side of the chest. And all of the leads that we would have put on the left side will actually move all to the same placements, but on the right side. And then V3R and V4R, which normally would have been on the right side of the chest, will now move across. So it's a complete reversal of the ECG. In terms of breast tissue, so the leads, we place them underneath the breast tissue, which means that we lift up the breast with the back of the hand, not the front of the hand. So we just move the breast tissue up and then place the ECG electrodes where they should be under the breast tissue. For patients who are on ECMO, if they have a sternal approach to the ECMO, then again, because the sternum will be open with a sternum approach, then we will leave those stickers off that we can't put because of the open sternum. And we do have patients in our unit with open sternums, and so they will either have a patch across the open sternum, meaning the bones aren't closed and the skin's not sewn, and so we will essentially just leave off. So we might have a tegaderm or, as I said, a patch. We would just leave off any stickers, electrode stickers that can't be placed in the appropriate position. Also, when we are putting those stickers on the patient, it's actually the middle of the sticker that goes in the correct position, not the little end that we clip on. So I'm going to show you a little video.
Today we are going to show you how to perform a pediatric ECG. First, we'll show you how to use the ECG machine, then how to place the leads across the chest, and then finally we'll show you how to print and transmit the recording. When you first press the power key, the pediatric ECG will display on the screen. Patient data corresponds with the F1 key, leads with F2, 25 millimeters per second, which is the speed of the ECG, with F3, 10 millimeters per millivolt, which is the height or amplitude of the ECG, with F4, 100 hertz, which is the filter of the ECG, with F5, and then there is a more, which corresponds with F6, which we'll explain later. On the right-hand side of the ECG machine, you'll see a copy key. You would press this key in order to make a duplicate copy of an ECG once you have pressed ECG. This will ensure that an additional ECG isn't sent into the Muse database system so that the physicians do not have to report on duplicate ECGs. We are now going to enter patient data by pressing F1. You'll enter the patient data in the normal manner by the keyboard. The ID number is the medical record number. For date of birth, you'll be placing the day, month, and the year of the patient. So enter the day first. For the month, you're going to press enter and either press the letter of the month, for example, if it was June, pressing a J, or you can toggle down to the proper month and press enter, and then the year. For gender, you will press enter again and choose the correct gender and enter. For test indication, you will need to place the diagnosis of the patient as well as any indications for doing the ECG, for example, postoperative or ST changes, and then enter. When you get to return, you just press enter again, and that patient ID screen will disappear, as well as you'll see the patient identifiers on the top left-hand corner of the machine. Ensure you have the right patient by checking for two patient identifiers, the patient's name and their MRN number, or their date of birth. We will be placing the electrodes according to the patient's right and left side. At first, we will place the right arm electrode on the patient's right arm bicep. We will then place the right leg electrode on the right leg around the calf area. Next, we will place the left arm electrode on the patient's left arm around their bicep. And then we will place the left leg electrode on the patient's left calf. In order to place the chest leads, we need to know the intercostal spaces. The first intercostal space often is located below the clavicle here. V1 will be placed on the right sternal border on the fourth intercostal space. So 1, 2, 3, 4. V2 is placed at the fourth intercostal space on the left sternal border. So first, second, third, fourth, V2. V4 is placed at the mid-clavicular border around the nipple line at the fifth intercostal space. So 4, fifth intercostal area, mid-clavicular. So that's V4. V3 is placed in between V2 and V4. Note that the electrodes are not touching here. V4R is the right-sided equivalent to V4. So on the right-hand side, mid-clavicular area, fifth intercostal space, V4R. V3R is placed in between V1 and V4R. The others will be placed according to the axillary area of the patient. What you will do, you will follow V4 and keep in a straight line across the axillary area. If you were to place the limb, the arm, up against the chest, V5 is at the proximal border of the axillary line. V6 is placed in the mid-axillary area, again following that same line across. V7 is placed on the distal portion of the axillary border. We will now be placing the leads on the electrodes. We like to place the limb leads on the patient first so that we get a partial ECG in case you need to quickly capture an arrhythmia that is happening. We will first place the right arm electrode by clipping it onto the black tab. Then the right leg electrode on the patient's right leg, the left arm electrode, and the left leg electrode. Now we can place the chest leads. V4R, V3R, V1, V2, V3, V4, V5, V6, and V7. On this segment, we will show you how to acquire and transmit your ECG. Once all the limb leads are attached, you should have a waveform coming across your screen. If you're seeing a flat line, it's probably due to a limb lead disconnection, as demonstrated on the screen. Once you are satisfied with your waveform of your ECG, you will now press the ECG button. If you haven't placed some leads, you will get a message asking you if you want to continue with the ECG. To continue, you will press F1. The record will now attempt to transmit. You must ensure that the transmission is complete before you turn off the machine. Sometimes you will have a modem error displayed. This is due to difficulties with interference in the room or a problem with the wireless network. If you see this error, you will press Cancel, which is F2. This will save the record onto the disk. This will later need to be transmitted into the database system. This concludes our basic introduction to pediatric ECGs.
Okay, so there are four little segments that we'll be going through. So that is sort of how to do a standard ECG. We'll also do troubleshooting, atrial wire study, and care of the patient with the open sternum in terms of performing a 15 lead. And so this is a little game. So I have to put these in the right spot. And if I put one in the wrong spot, it's quite sensitive, this little game, but it's a good way to practice. So remember, we're going to, there's our suprasternal notch, there's our clavicles, there's our first intercostal space, second intercostal space, third intercostal space, and fourth intercostal space. So I'm going to move this little one down into the fourth intercostal space, right sternal border. I'm going to move V2 into the fourth intercostal space, left sternal border. Then I'm not going to do V3. I'm going to do V4 next, which is in the fifth intercostal space, mid clavicular line. Okay, and then I'm going to take V3 and insert it where it should go, which is halfway in between the two. Then I'm going to forget about V5, and I'm going to take V6, and I'm going to place it in the same fifth intercostal space, but mid clavicular line. Sorry, sort of anterior or mid axillary line, I should say. Sorry about that. And then I can place V5, which is halfway between V4 and V6. And then I can take V7, which is around the posterior axillary line, like that. And then I'm going to place V3R and V4R. So again, V4R is going to be the first one that I'll place, mid-clavicular line, but on the right sternal, on the right midclavicular line on the 5th intercostal space. And V3R, I'm going to put midway between V1 and V4R. And so now I'm going to see whether that's correct or not. Right? So the other thing I always think that's really important is once you place the ECG stickers in the correct position, and remember I've already put on the limb leads because that should be one of the first things that you do, because then at least in an emergency you get a rhythm. But once you put your leads, attach your leads to the sticker of all of those electrodes that you placed on the patient, always do a double check. So place them all and then do another double check before you press ECG. Because again, if you've mixed the leads, then the information that the cardiologist or physician is going to read will not be correct. So we have to make sure that everything is correct so that we have an accurate picture that we're giving to them. So here's a little knowledge check. What are the two main identifiers that you must include in patient data screen? Well, patient name and MRN, patient MRN and referring physician, patient name and test indication, patient MRN and technologist name. So ideally we want all of that information into our 15 lead machine, but we must have the patient name and MRN so that we can reconcile to the patient's chart. Okay, so you can have any two identifiers. So match the following ECG electrode placement location with the corresponding chest lead. So 4th intercostal space, right side of the sternum, is going to be our V1 placement. 5th intercostal space, midclavicular line on the left chest is going to be our V4. Right side midpoint between elbow and shoulder is going to be our right arm lead. And then the 5th intercostal space posterior axillary line on the left chest is going to be our V7. And our 5th intercostal space anterior axillary line on the right chest is going to be our V5. Okay, waiting for it to move forward. Oh, continue. Once the ECG electrodes and wires are connected, which button should you press in order to ensure that the ECG is transmitted into the Muse database? Of course, this is a sick kid specific question because your system might be quite different unless you work here. So for us, it's the ECG. So copy, we can make as many copies as we want, but ideally we want to find one good ECG, press ECG button, and then it transmits up to the Muse database. You're performing a 15-lead ECG on a 3-month-old baby who's crying and moving around. What steps should you take to ensure that the ECG is of good quality for interpretation? Make sure the ECG is free of artifact before pressing the ECG button. Pat the baby's chest during the recording. Use bigger ECG electrodes for stronger adherence. Keep pressing ECG until you get a good quality ECG. So basically, we want to try and wait for a good quality ECG before pressing it. So in performing a 15-lead ECG on a patient with known dextrocardia, which lead should you move to the right side for dextrocardia ECG recording? So remember we said we were going to do a standard ECG first, and then we were going to move our left-sided V5, V6, and V7 across to our right side, and on the paper copy we would write V5R, V6R, and V7R. And also for test indication, we would write dextrocardia 15 lead. Now, remember, so this will be the answer on this, but remember, now at sick kids, we completely reverse all of the leads. So the V1, which normally would be on the right sternal border, will go across to the left side, and all of the left-sided leads will completely go across to the right chest. As well, our V4R and V5R, which are normally placed on our right chest, will come across to our left. So we've done a complete reversal. And again, on our ECG paper copy, we will write 15 lead, and on our electronic copy, we will have typed in 15 lead. So a 3-month-old baby boy was seen in the emergency department for assessment of pallor and distress. A 15-lead ECG performed by the nurse is shown below. Which of the following is the most likely cause of this poor quality recording? Stray current from ECG machine, interference from the IV pump, right arm wire is damaged, respiratory artifact, or the right electrode is falling off. So I'm going to show you a closer look at the ECG. But you can see all of this baseline sway, which is most likely related to the fact that this patient is breathing. So a respiratory artifact. So transmitting the ECG over Wi-Fi connection. So again, this is specific to sick kids. So ECG should transmit in patient care rooms automatically. So don't turn the machine off until you've observed the words transmitting come across the screen. Sometimes you just might need to move it to the middle of the room. And if failure to transmit, we want to press cancel so it gets saved to the disk, and then we can go and manually transmit it under the more button. And we have to remember that if we have pressed cancel because it didn't automatically transmit up to the Muse database where the ECGs are stored, and then the physicians read it, and that's somebody validating and verifying the information that the 12-lead machine has written on it, or we want to make sure that the information that gets transmitted into the patient's chart is actually correct, validated by an expert. So all 15 leads, even if they're reviewed at the bedside by the fellow or other physicians, it is always reviewed by someone else. So this is just how we do it. So using the function key on top of the keyboard, we go to our main menu, press more, go to File Manager, and we select any that may be sitting there and press Transmit. So our process is that, if you know that you had to press cancel and it's sitting there, then we would go to another area and try to manually transmit it later. And also our charge nurses should do that as part of every shift. If they don't do that, what happens is the ECG doesn't get transmitted, and then there's a delay in it being read formally, and that might actually, relate to a delay in care. So knowledge check again, common reasons for failure of the ECG to transmit to the Muse database, or the Muse database not to receive the ECG, are the wireless system is down. The end user turns off the ECG before it has had time to transmit, so we're waiting to see it saying transmitting and transmitted. In that particular location of the patient room, there is no wireless, so we might need to move it to another location. And the end user doesn't go back within the shift to transfer anything that have saved to the disk. What are the appropriate steps to take when the ECG fails to transmit automatically? Please place in the correct order. So the choices are: try to transmit again after moving the machine to another place in the room. ECG must later be transmitted to the Muse manually. And if it still does not transmit, select cancel, and the information will be saved to the machine. So I'm just going to move this one up because it's an ordering question, so that we're going to try and transmit it by moving the machine to another place. If it doesn't transmit, we're going to select cancel, and then it must be manually done later. So troubleshooting is the next section which we'll examine. And so there are a number of sources of artifact. So we need to try and clean up the artifact to get a good 15-lead ECG. So sources of artifact can be the overbed warmer wires that come down, that the wires with a little disc on the baby's abdomen giving feedback. So that may affect it. IV tubing or infusion pumps, monitor electrodes touching ECG electrodes, electrical noise artifact, DVD players, cell phones, electronic devices. So corrective actions would be to move bedside monitoring electrodes away from the 15-lead ECG electrodes, put blankets or towels between the IV tubing and the leads if they are causing interference, and move away all electronic devices. Also, it could be that our electrode package is dry. So usually there's a number of electrodes that come in a package. So once you open the package, if it's sitting there for a long time, it might dry out and not produce the best waveform, in which case it's be better to open up a new package. The electrodes are sliding off. Well, sometimes, for instance, when we have newborn babies or we've just put creams on our patient, then that might be a reason why you just stick the electrode on and it's busy sliding off when you attach the clip to it. So we could wipe the skin with an alcohol swab or soap and water. We need to let it dry. We could try Cavalon wipes or even tape down the electrode. In active patients, so for active patients who are unable to stay still, such as with tremors or shivering, well, we could try and move the limb leads, the ones on the arms and the legs, closer to the core of the body. So move the upper arms, for instance, up to the shoulder. And then if there's muscle contraction, so noise interference, thick baseline on ECG recording and one or more leads, we should try and wait till the patient's relaxed. And then common made errors we've talked about quite a bit, which is patient identification. So we need to make sure that we have this information on. Otherwise, it may not actually get to the patient's chart. In terms of lead placement, inappropriate lead placement, so with an open sternum or a thoracotomy, trying to put leads over a dressing, the electrodes over a dressing, or over an area, we actually displace them because we can't put it over the open sternum area. So remember, we need to remember just to leave those ones off. So when dressings are obstructing lead placement, e.g. lung transplant or full chest dressing, sternal dressing, just leave off the ones where if you can't apply them in the proper spot. But don't try to apply the leads that overlie an incorrect area. Inaccurate placement, we can't stress enough, causes inaccurate diagnosis. So if only some of the leads can be placed, then that's fine. We'll just read the leads that can be placed properly. In small infants, damage may occur to the nipple if you're placing the stickers on the electrode sticker on the nipple, and as you remove it, it might tear fragile tissue. So do not place stickers directly on the nipple tissue. Multiple ECGs, we've talked about that. It's best to wait for one good ECG, then press it, because remember, if we're doing multiple ECGs, they get stored and sent up to our Muse database, where the poor cardiologist or whoever is reading them have to read multiple ECGs. If we want more copies, we just press copy. And then we can go into our file manager obviously if it's transmitting, then automatically then we would not be able to go there in time. But if it's not transmitting and we've pressed multiple ECGs, we could actually select the ones that we want. Otherwise, that process does happen in the heart station by our ECG technologists. So here's a quick video on troubleshooting.
For this segment, we'll be discussing troubleshooting, flat lines demonstrated on the ECG, electrical interference, manual transmissions of the ECG, and modifications to positions. First of all, if there is no waveform present across the ECG, it is one of two problems. It is either that the acquisition module has come unattached from the cable, or there is a limb lead that is affected. So ensure that your limb leads are attached to the patient, like so. If on your limb leads you are seeing a flat line on any lead, it is normally due to a limb lead reversal. So ensure that your right arm is on your right arm of your patient, the right leg and left leg are not reversed. And if so, reverse them. If you're seeing a flat line on any other lead, you need to be looking, first of all, at the electrode. Ensure at the spot of the electrode that the skin isn't very creamy, or if the electrode doesn't seem well attached. If so, you will need to remove the electrode, clean the area with alcohol, and then attach a new electrode. If that doesn't solve the problem, the next thing to check is the clip. You want to make sure that there isn't any gunk that is attached within here that might be affected your clip. If this is the case, you're going to remove the clip from the end of the lead identifier as so, and attach a new clip, and then reattach it to the electrode. If this does not solve the problem, ensure that you don't have a partial disconnection from the lead identifier and the lead, like so, that the lead on the other end isn't unattached from the lead position, and if so, you will want to reattach it. If this doesn't solve the problem, you will then need to replace the actual lead. To do so, ensure that you are taking off the lead from the proper position and pull it out of the acquisition module. Unattach the lead identifier by twisting, like so, and attach a new lead. Ensure that you are attaching the new lead in the right spot in the identifier, and reattach the lead. There are three main causes of electrical interference, one of which is creamy or oily skin, as discussed previously, monitor electrodes placed close to where the ECG electrodes are, or IV tubing that is attached to infusion pumps. If it is a case of a monitor electrode being close to where your ECG electrodes are, you will need to move your monitor electrode away from there. If it's a case of IV tubing, you will need to place a blanket in between the lead affected and where the IV is. In some patients, breast tissue may interfere with the position of the electrode. You would need to lift up the breast tissue and place the electrode as close to the rib cage as you can at the 5th intercostal. If you weren't able to automatically transmit the recording, we will now need to manually transmit the ECG. To do so, we are going to go to More, which is indicated by the F6 button, and go to the main menu, which is now at the F2 position. We then need to get to the File Manager, so again we're going to select More and select File Manager, which is at the F1 position. Now all the ECG records will be displayed on the screen. We will then go to Select All Records, which is the F2. We are now going to transmit the records by selecting Transmit, which is at the F4 position. The record will now attempt to transmit. You must ensure that the transmission is complete before you turn off the machine. Sometimes you will have a modem error displayed. This is due to difficulties with interference in the room or a problem with the wireless network. If you see this error, you will press Cancel, which is F2. This will save the record onto the disk. This will later need to be transmitted into the database system. First of all, you're going to press the button, which is located on the upper left-hand corner of the ECG machine. Then you're going to make sure that you place the paper with the circle towards the upper left-hand corner. Slide it into the machine and pull out the top 2 pages. You can then close the lid and securely fasten the machine in place.
Okay, so next is our knowledge check on troubleshooting. So which leads are always required when performing an ECG? So please correct all answers that apply. So we always need to have our limb leads on. Just going to select them. And remember, in a hurry, we're going to put them on first and take the outer 2 of our leads, so the limb leads from our manifold, and put them on those stickers. And then we can take our time and do V1 through V7. So you're doing an ECG and get a thick baseline. You know this represents electrical noise. How can you counteract it? Well, you can put blankets or towels in between the IV tubing and leads. We don't want to place our electrodes over dressings. Ask your patient to speak more quietly on their iPhone. Move bedside monitoring electrodes away from the 15 lead electrodes, and move away any electronic devices. The rhythms are stored on the Muse database, so that's true in our setup here or our system here. Oh, sorry, it's saying rhythms. So yes, I got that wrong. So ECG is stored on our database, but rhythms are not stored. So when we're doing a rhythm strip, remember we're going to pick lead 1, 2, and 3, or V1, lead 2, and V5, and we're just going to print it for the bedside, stick it in the paper chart versus the electronic, and those don't transmit. How do you perform an ECG on paper on a patient with dextrocardia? How do you perform an ECG on a patient with dextrocardia? Drag and drop in the correct order. So we're going to perform a standard ECG. Oops. And then we're going to place V5, V6, and V7 on the right side, and we're going to put V5R. And then we're going to write an R on the lead paper. But remember, the way we would do it now would be we are going to completely reverse all of the leads. It's our new way of doing it over the last year at Kids. So here we go again. We get another opportunity to place everything in the right spot. So remember V lead, or in the interspace 1, 2, 3, 4. Right sternal border is V1. V2 is in the left sternal border in the 4th intercostal space. We're gonna wait and hold off on V3. We're gonna drop down to the 5th intercostal space and do mid-clavicular line. And then we're gonna take V3 and put it halfway in between. We're gonna forget about V5 for the moment, and we're still gonna go not down like a bird's feather, right? We're going to go across in the same, in the mid-axillary line for V6, whoops, V6. And then we're going to put V5 in the middle, just for standard ECG, and V7 is going to go in the posterior, whoop, just put that again. Oh, it's got a mind of its own. There we go, so I'm going to put that around here. And this popped out of place, halfway in between. And then we're going to do V4R next. Mid-clavicular line. 5th intercostal space. Okay, and then we're going to put V3R halfway in between. Okay, That's correct placement for a standard 15 lead ECG. What does a flat line mean on one of the leads? A lead has not been attached, electromagnetic interference with that lead, improper grounding of the machine, the gel of the electrodes are touching each other. So remember, we are going to leave leads off if they're not in the right spot. Next section is patients with an open sternum. So always omit V1 and V2. You may even have to omit V3 and V4 if they can't be placed properly. Only place electrodes that can be placed in the correct position and are touching part of the patient's skin. So do not place leads in an inappropriate position. This could lead to misinterpretation of events. So for example, with a large tegaderm, only V5, V6, and V7 may be able to be placed. With a narrow tegaderm, maybe you might get these V3R, V4R, and V3 and V4 on. So there's an example. This obviously still has its border on the tegaderm because it's just a piece of paper, laminated piece of paper. But we're only placing things where they should be. So another little video.
For this segment, we'll be discussing performing ECGs on patients with open sternum, sternal dressings, and atrial wire studies. Independent of patient situation, you need to ensure 2 patient identifiers, and you must place the limb leads on both the arms and the legs. In the situation of a patient with an amputee, say in this case a left leg amputee, you would take the left limb electrode and you would place it up on the torso. You will not be placing any electrodes across any area where there is a dressing. In this case, between V4R and V4, we will not be placing any electrodes. If you have a patient with an open sternum, you will need to approximate the position of the 5th intercostal space, and you will place your leads on the lateral side, V5, V6, and V7. When you are looking at the ECG screen, you will notice that there are flat lines on the areas where there are no leads present. When you press ECG, it will inform you that the leads are off. Press continue to store your ECG.
So another quick knowledge check. See how we do. So in a patient with an open sternum, placing V1 on the outer edge of the tegaderm dressing is appropriate. False. We also don't want to lift the dressing because underneath there is the heart. Waveforms will transfer through tegaderm. False. In a patient with an open sternum, after pressing ECG, when an error message occurs stating that the leads are off, you should press continue. That's true. You're just acknowledging that double checked and the leads are off. And the final section is the atrial wire study. So atrial wire studies we might do in patients with atrial flutter or when we're not sure where the P wave is. So if you can see consistent P waves, then that's not an indication to do an atrial wire study. So an atrial wire study uses the temporary pacing leads placed on the epicardium during cardiac or during surgical procedures. So essentially, patients who have been through cardiac surgery have a sternal incision, and just before they wire the bone shut and either put a suture through the skin, they are going to put some thoracic pacing wires. So these are temporary pacing wires that are in there for maybe the first few days, or depending on more chronic patients, they may stay longer. But they are removed, the morning usually before the patients go home. So if the patient is having atrial arrhythmias, you can't consistently see the P wave, then we're going to clip either the limb leads or the V1 and V5 onto the atrial pacing wire that comes out. So in a sternal incision, the standard way when we have pacing wires, the one on the right of the sternum is the atrial wire, the one on the left of the sternum is the ventricular wire. So we're going to hook them up to the atrial wire, and we'll show you in a little video. So depending upon the staff physician, some people like to do an atrial wire study using limbs 1, 2, and 3, or leads 1, 2, and 3, and others like it in V1, lead 2, and V5. So there's an example of lead 1 and lead 2 and lead 3, or the other type where it's V1 that's hooked on and V5 that's hooked on to the atrial pacing wire, versus up here where the limb leads were. And the atrial signal gives a very sharp little spike. So you can see here that the atrial signal, and we'll have a whole section in semester 2 on atrial ectopic tachycardia and junctional ectopic tachycardia. But here, this atrial wire study is sort of delineating the P wave with a sharp spike.
You may be asked to perform an atrial wire study if the P waves are not visible on either the monitor or the ECG. We will be demonstrating 2 different ways of performing an atrial wire study. One, attaching the right arm and left arm electrodes, which forms a bipolar signal, or V1 and V5, which will show a unipolar signal. Before you perform an atrial wire study, first perform a normal ECG. Then what you will do is locate the atrial wires. The atrial wires are located on the right side of the patient's chest versus the left side, which are the ventricular wires. If the atrial wires are attached to a temporary pacemaker, you will need the assistance of the physician in order to proceed. There are 2 ways of performing an atrial wire study. The first way is to attach the right arm and left arm electrodes to the atrial wire prongs. You must ensure that your left leg and your right leg electrodes are still attached. You will then run the paper on leads 1, 2, and 3. Unlike an ECG, where an atrial signal is a P wave, on an atrial wire study, it will demonstrate as a sharp deflection, like a pacing spike. Sometimes the physicians might ask for a different type of atrial wire study so that they can see a surface ECG on the recording. In order to do this, you're going to attach V1 and V5 to the atrial wire electrodes, and you will run the rhythm at V1, 2, and V5. On the ECG, it will look like so.
Okay, so the final knowledge check then. So when might a patient require an atrial wire study? So routinely after surgery, when P waves are regular and visible, when ruling out atrial flutter, when P waves are not clearly visible, are the only 2 indications. All limb leads must be attached in order to perform an atrial wire study on V1, lead 2, and V5, and that's true. Temporary pacing wires can be used for the following. Please choose all that are correct. To pace a patient, well, that's why we generally use them in place of leg leads, and to sense P waves and diagnose atrial arrhythmias. Okay, So remember, I messed up that one question, but we got 95%. So that's pretty good. All right. All right. So I think that's the main things that we want to communicate to you on in terms of taking 15 lead ECGs. And the main pieces are ensuring that we have good placement of our electrodes, that we wait for a good ECG, and that's the one that we want in the patient's chart. And we think about all the troubleshooting that we need to do in order to minimize interference. That if a patient is dextrocardia, it's sick kids, we basically reverse all of the leads now. Again, that might be different where you work. And that if we need to do an atrial wire study, that we we find out from the physician whether it's lead 1, 2, or 3 that they want the atrial wire study done, or V1, lead 2, and V5. And our main things are that we ensure we have the patient identifiers in, we have the reasons why we are doing the ECG, and that we absolutely make sure that we put the stickers in the correct placement. So hopefully this was helpful in terms of your understanding and application of principles and practices around 15 leads. Thank you.